Hi class, today we will be covering chapter 16, which is the physiology of the respiratory system. We will look at the anatomy and functions of the respiratory system, as well as the physical aspects of ventilation itself. We'll look into mechanics of breathing, gas exchange that occurs in the lungs, the regulation of breathing. We'll look at hemoglobin and oxygen transport, as well as transport of carbon dioxide gas. We'll look into acid-base balance of the blood within the respiratory system. And finally, we'll take a look at the effect of exercise and high altitude on respiratory function. Let's first take a quick review of the respiratory system and its functions. This involves ventilation, which is the mechanical process that moves air in and out of the lungs. Gas exchange between the blood and the lungs. So within the lungs, you're taking in oxygen from the outside into your lungs, and at the level of the lungs, oxygen moves from the lungs into the bloodstream, and carbon dioxide moves from the bloodstream into the lungs. Also, there's gas exchange between the blood and the tissue at the tissue level. So at that level, the oxygen from the blood will leave the blood to go to the tissues, and carbon dioxide that is accumulating in the tissues will then move into the bloodstream to be delivered to the lungs. There's also oxygen utilization by the tissues in order to make ATP. This is a process called cellular respiration, as you guys can recall from anatomy. And then ventilation and gas exchange in the lungs occurs at the level of the lungs. This is called external respiration. There's also internal respiration, which is the oxygen utilization and the gas exchange that occurs at the level of the tissues. One might wonder, how does gas exchange occur? So in the lungs, gas exchange occurs by way of diffusion, where gas moves from a higher concentration to an area of lower concentration. So that means for oxygen concentration is higher in the lungs than in the blood. So that means that the oxygen diffuses into the bloodstream, whereas carbon dioxide concentration in the blood is higher than in the lungs, and so the carbon dioxide will diffuse out of the blood. Anatomically, this is divided into conduction zone versus respiratory zone, whereby the conduction zone gets air to the respiratory zone, so it's moving air to the respiratory zone, and the respiratory zone is the site where the gas exchange occurs. Now the alveolus, singular, alveoli is plural. These are air sacs in the lung where gas exchange occurs. There's 300 million of these alveoli, which provide large surface area in order to increase the diffusion rate. So the surface area is somewhere it's about 760 square feet of surface area that is allowing for diffusion to occur. Each alveolus is one cell layer thick, but it has great tensile strength, and they form clusters at the ends of the respiratory bronchioles. Now, if you look at the picture on the right-hand side, you can see that type 1 alveolar cell, type 2 alveolar cell, and macrophages are found in the alveolus. Also, the fluid with surfactant, as well as capillaries with red blood cells and white blood cells are shown here in this picture on the right-hand side. As you may recall from anatomy, the septum of the alveolus is lined by alveolar cells, also known as epithelial cells or pneumocytes or pneumatocytes. There are two types, type 1 and type 2. Type 1 alveolar cells make up 95 to 97% of the total surface area of the alveolus, allowing for gas exchange to occur. So these are very, very thin cells, flat cells, and their shape optimizes the ability of gas to diffuse across the lining. The type 2 alveolar cells secrete pulmonary surfactant, which will reduce the tension on that surface lining and thereby increase the compliance of the lung as well as lower the work of the lung. The pulmonary surfactant that's secreted is very helpful to prevent collapse of the lung. Type 2 cells also reabsorb sodium and water, and they prevent fluid buildup. This micrograph shows 3 alveolar air spaces, and take a look at the septum and the cells that make up the septum. See if you can identify the type 1 and type 2 alveolar cells as well as the dust cells found in the lumen. And see if you can locate the capillary endothelium and the red blood cells found in the capillaries. As a recall from anatomy, you should be able to trace the pathway of air as it travels through the respiratory tree, going from the nasal cavity to the pharynx, the larynx, the trachea, the primary bronchi to the secondary bronchi and tertiary bronchi, branching many times through the bronchioles to the terminal bronchioles, the respiratory bronchioles, and eventually the alveolar ducts and alveoli. Here we're looking at the conducting and the respiratory zones. One trachea branches to 2 primary bronchi, and these will then branch multiple times to form a total of 60,000 terminal bronchioles. Each of these branches further, resulting in a total of 500,000 respiratory bronchioles and 8 million alveolar air sacs. Now, at the level of the trachea and the respiratory bronchi, the thyroid and cricoid cartilages of the larynx, the trachea, the carina, the left primary bronchus, and the right pulmonary bronchus are all labeled in this illustration. The micrograph shows the trachea, the bronchi, and the bronchioles as well. The ventricular fold is also known as the false vocal cord. The true vocal cord is also known as the vocal fold. And then you can also see the glottis is labeled here as well. Recall that you learned in anatomy the difference between the conducting zone and the respiratory zone when we talked about the respiratory system. The conducting zone transports air to the respiratory zone. Voice production takes place in the conduction zone at the larynx as the air passes over the vocal folds. The air is warmed, humidified, filtered, and cleaned. And mucus is secreted by the cells of the conducting zone, and it traps small particles. Mucus moves along by cilia that beat in a coordinated fashion. This is the mucociliary escalator, and it goes to the pharynx where it can be cleared by swallowing or expectorating. The process is called mucociliary clearance. In cystic fibrosis, the mucociliary escalator fails to function properly because the mucus is too thick for the cilia to properly get cleared. In patients that have cigarette smoking habits, their cilia also becomes damaged, and this will reduce mucociliary clearance. Recall that the thoracic cavity contains the heart, the trachea, the esophagus, and the thymus within the central mediastinum, and the lungs fill the rest of the cavity. There is the parietal pleura that lines the thoracic wall, and the visceral pleura, which covers over the lungs. Both of these pleura are normally pushed up against each other, close together, with a potential space between them called the intrapleural space. The diaphragm is a dome-shaped skeletal muscle of respiration that separates the thoracic and the abdominal cavities. Let's take a moment to look at this thoracic cavity cross-section, which labels for us and helps us to review the location of the heart in the middle of the mediastinum, the parietal pleura, the visceral pleura, the pleural cavity between them, the bronchus, the posterior mediastinum, the thoracic vertebrae, the sternum, the pericardial cavity, the anterior mediastinum, the thoracic wall and the lung, the parietal as well as the visceral pericardium, and the esophagus. Let's also take a moment to review the x-ray of the lungs here, where you can see the black is where the air is, so that's where the air is contained within the lungs. The base of the lung down below shows the diaphragmatic surface, where the diaphragm divides the thoracic cavity above from the abdominal cavity below. You can see the apex of the lungs on the top there. You can see the mediastinum and the heart, as well as the esophagus in the center between the two lungs. And the ribs that border the outside of the lungs are visible here in that white ghost shadow. We're moving now to a discussion of the physical aspects of ventilation. Ventilation, also known as breathing, is the physical process of moving air into and out of the lungs, allowing for gas exchange between the body and the environment. The air moves from high to low pressure. The pressure difference between the two ends of the conducting zone occur due to changing lung volumes. And compliance, elasticity, and surface tension are important physical properties of the lungs. There are different types of pressure. The atmospheric pressure is the pressure outside the body, which acts as the reference point. There's the intrapulmonary pressure, also known as alveolar pressure or intra-alveolar pressure, which is the pressure within the alveoli, within the air sacs of the lungs. And then there's the intrapleural pressure, which is the pressure within the pleural cavity, the space between the lungs and the chest wall. It contains a thin layer of fluid that serves as a lubricant to reduce friction when those two layers rub up against each other. Now, as we look at the pressure differences when breathing, during inhalation, contraction of the diaphragm and intercostal muscles increases the thoracic cavity volume, decreasing the intrapulmonary pressure and allowing air to flow into the lungs. So for inspiration or inhalation, the intrapulmonary pressure is going to be lower than the atmospheric pressure. And the pressure below that of the atmosphere is called the subatmospheric or negative pressure. Generally, this is about -1 centimeters of water. During exhalation, muscle relaxation causes the thoracic cavity volume to decrease. This raises the intrapulmonary pressure and expels the air. So in exhalation or expiration, intrapulmonary pressure is going to be greater than the atmospheric pressure, and this is going to be generally about +1 centimeters of water. Spend some time reviewing table 16.1, which covers the pressure changes in normal breathing, particularly the peak values of the pressure differences from atmospheric in quiet breathing. Note that intrapleural pressure, the pressure within the pleural cavity, is lower than the intrapulmonary and the atmospheric pressure in both inspiration and expiration. And the difference between the intrapulmonary and intrapleural pressure is called the transpulmonary or transmural pressure and is positive during inspiration and expiration. It keeps the lungs against the thoracic wall and it allows for the lungs to expand during inspiration. So Boyle's law states that at a constant temperature, the pressure of a gas is inversely proportional to its volume. So if you increase the volume in which a gas is contained, the pressure decreases, and if you decrease the volume, the pressure would increase. How this applies to breathing is that breathing depends heavily on this principle to move air in and out of the lungs. When we talk about intrapulmonary pressure, for inspiration, the diaphragm and intercostal muscles contract, expanding the thoracic cavity and increasing the lung volume. By Boyle's law, increasing the volume would lead to a decrease in intrapulmonary pressure. When the intrapulmonary pressure drops below atmospheric pressure, air flows into the lungs. As it applies to expiration or exhaling, the diaphragm and the intercostal muscles relax, reducing thoracic cavity volume. And as the volume decreases, the intrapulmonary pressure increases above atmospheric pressure. This pressure difference would push the air out of the lungs. So lung compliance refers to the lung's ability to stretch and expand in response to pressure changes. It's a crucial property in respiratory physiology, representing how easily the lungs can inflate with each breath. So lung compliance is defined as the change in lung volume for a given change in transmural or transpulmonary pressure. This means a lung with high compliance requires less pressure to achieve the same increase in volume as a lung with low compliance. So it's delta V over delta P. So it is the ease with which the lungs expand under pressure. That's what lung compliance is. And it's reduced by the factors that produce a resistance to distension, such as the infiltration of connective tissue proteins in pulmonary fibrosis. This is the case of low compliance. It indicates stiffer lungs. It makes breathing more laborious, harder to breathe. Other cases of low compliance would be acute respiratory distress syndrome. In the opposite direction, we have high compliance, which indicates overly pliable lungs, often with poor recoil. So the lung can expand easily, but it won't relax back to its normal position. And we see that with emphysema. These lungs inflate easily, but empty poorly. So properties of the lungs include elasticity. The lungs can return to its initial size after being stretched. This is called recoil. The lungs have lots of elastin fibers because the lungs are stuck to the thoracic wall. They are always under elastic tension, and the tension increases during inspiration and reduced by elastic recoil during expiration. So again, this is elastic recoil, where the lungs with high elastic recoil, those that are considered stiff lungs, as in fibrosis, have low compliance, while those with low recoil, such as emphysema patients, have high compliance. Surface tension is another physical property of the lungs which resists distension and makes it harder for the alveoli to distend, to expand. It raises the pressure of the alveolar air as it acts to collapse the alveolus. Alveolar surface tension, reduced by pulmonary surfactant, significantly increases the lungs' compliance by making it easier for alveoli to expand. So even though surface tension will resist distension, surfactant reduces that surface tension and makes the compliance of the lung greater. People with cystic fibrosis have a genetic defect that causes an imbalance of fluid absorption and secretion. So here we're looking at the law of Laplace, which shows the relationship to surface tension. The law of Laplace describes how pressure, surface tension, and radius interact in spheres and cylinders, which is highly relevant for understanding surface tension in structures like the alveoli in the lung. The core principle here is that for a curved fluid surface, such as a bubble or an alveolus or a droplet, the pressure difference, delta P, between the inside and the outside is determined by the surface tension and the curvature, or the radius r, of the interface. So for a sphere, such as a soap bubble or an alveolus in the lung, you're looking at delta P equals 2 times T over R. So this means that smaller spheres have a higher internal pressure for the same interface. If we look over on the image to the right here, you'll notice the law of Laplace is 2 times T over R, and in this smaller alveolus, the R is 1, so P is 2 times T over 1, which is 2T. In the larger alveolus, the R is 2, so P is 2 times T over 2, which is T. How does this relate to, or how is this biologically relevant? So the alveolus, for the alveolus, the air sacs of the lungs are nearly spherical. According to Laplace's law, smaller alveoli would collapse into larger ones if not stabilized, since the pressure needed to keep them open is inversely related to their radius. For surfactant, the body uses surfactant to lower the surface tension, especially in smaller alveoli, therefore preventing collapse and equalizing pressure among the alveoli of the different sizes. So in the case of a pneumothorax, this occurs when air enters the pleural space, raising the intrapleural pressure so that the pressure difference keeping the lung against the chest wall is eliminated. This is that area, it's entering the area between the lung and the chest wall. This presence of air creates pressure in the lung that causes it to partially or fully collapse. And it's sometimes called a collapsed lung due to its elastic recoil. You can also have a spontaneous pneumothorax, which happens without injury or obvious cause, but it may occur without disease or trauma by air leaking from the lung due to puncture from a broken rib or to a lung disorder such as COPD or cystic fibrosis or rupture of a lung blister. An open chest wound can also allow air to enter the pleural space, producing a serious tension pneumothorax. And each lung is in a separate pleural compartment, so if a pneumothorax occurs, it will usually only occur to one lung and not both lungs at the same time. So a chest x-ray is the primary tool for diagnosing a pneumothorax. Here are the key features to look for when you're looking for a pneumothorax. Hallmark radiographic signs include visible visceral pleural lines that appear as a thin, sharp, white line outlining the collapsed lung. This represents the edge of the separated lung tissue. An absence of lung markings beyond the pleural line, so no lung markings are seen peripheral to the pleural edge, indicating air in the pleural space. And then also increased radiolucency, so the area outside the visceral pleural line would appear darker or more lucent than normal lung fields due to the presence of free air. And then you may also see collapsing lungs, so the remainder of the lung may appear smaller or denser, pulled away from the chest wall. Surfactant is a surface active agent secreted by type 2 alveolar cells or pneumatic cells. And they consist of hydrophobic proteins and phospholipids. They're responsible for lowering the surface tension between the water molecules by reducing the number of hydrogen bonds between water molecules, and they're more concentrated as the alveoli get smaller during expiration. The function of the surfactant is to prevent collapse, so they allow a residual volume of air to remain in the lungs. If you look at the image on the right-hand side, we're looking at production of surfactant, pulmonary surfactant here. The surfactants present in alveoli are important in maintaining the surface tension of the alveolar fluid. And so the type 2 alveolar cells called pneumocytes produce this surfactant. It's composed again of phospholipids and proteins. Dipalmitoyl phosphatidylcholine is the strong surfactant present in lungs. Respiratory distress syndrome is a condition involving serious breathing difficulties. It most commonly affects newborns, especially those born prematurely, because their lungs are not fully developed and they lack enough surfactant, that substance needed to keep the air sacs in the lungs open. In adults, a closely related but distinct condition called acute respiratory distress syndrome is present, which can be triggered by various illnesses or injuries. So in the case of respiratory distress syndrome, again, production of surfactants began late in fetal life, so the premature babies may be born with a high risk for collapse of the alveoli, and in this case, they would be treated with surfactant. In adults, the similar condition is called ARDS, acute respiratory distress. It can be caused by septic shock or pneumonia, reduced lung compliance, reduced surfactant, and it produces hypoxemia, so low levels of oxygen in the bloodstream. So we'll now move on to the mechanics of breathing. Breathing involves the movement of air in and out of the lungs by creating pressure gradients within the chest cavity. And this process is divided into two phases: inspiration or inhalation and expiration or exhalation. And it's accomplished by changing the thoracic cavity or the lung volume. The thorax has to be rigid enough for protection, but flexible enough to act as bellows for breathing. So as you guys know from anatomy, breathing involves muscle actions. The diaphragm contracts and moves downwards. The external intercostal muscle contracts, pulling the rib cage upward and outward. The effects on the thoracic cavity is that these actions increase the volume of the thoracic cavity. There are pressure changes where the increased volume causes decreased intrapulmonary pressure. The pressure drop will create a gradient causing the air to rush into the lungs. The nature of this process is an active nature because it requires the muscle contraction and energy. In case of expiration, muscle actions involve the diaphragm and external intercostal muscles relaxing, and the rib cage moves downwards and inwards, causing the volume of the thoracic cavity to decrease. And this decreased volume causes increased intrapulmonary pressure. The air is then forced out of the lungs. And this is going to be more of a passive process during quiet breathing, primarily relying on the elasticity of the lung tissue and the relaxation of muscles. But it can be active during forced exhalation, involving internal intercostal and abdominal muscle action. This slide shows you that the scalenes, the pectoralis minor, and the sternocleidomastoid are used for forced inspiration. They elevate the rib cage more. For quiet expiration, this occurs with the relaxation of the inspiratory muscles. Again, this is a process that is passive. The abdominal muscles are used for forced expiration as well. When you look at the image on the right-hand side, the muscles of inspiration include the sternocleidomastoid, the scalenes, the external intercostals, the parasternal intercostals, and the diaphragm. Whereas the muscles of expiration include the internal intercostals, external abdominal oblique, internal abdominal oblique, transversus abdominis, and the rectus abdominis. So again, with breathing, inspiration, The volume of the thoracic cavity and the lungs will increase vertically when the diaphragm contracts or flattens, and laterally when the peristernal and external intercostals raise the ribs. The lung and thoracic volume will increase, leading to intrapulmonary pressure decreasing, and that pushes the air into the lung. During expiration, the volume of thoracic cavity and the volume of the lung decreases vertically when the diaphragm relaxes or becomes dome-shaped, and laterally when the external and peristernal intercostals relax for quiet expiration, or internal intercostals contract in forced expiration to lower the rib cage. The thoracic and lung volumes decreasing causes the intrapulmonary pressure to increase and therefore lets the air out. So here we can see the mechanism of pulmonary ventilation. At rest, the intrapulmonary pressure is the same as atmosphere. Intrapleural pressure is -5 centimeters of water. During inspiration, the intrapulmonary pressure is -1 centimeters of water. Intrapleural pressure is -8 centimeters of water. During expiration, the intrapulmonary pressure is +1 centimeter water, and intrapleural pressure is -5 centimeters water. During your studies, make sure to take a look at table 16.1, which compares quiet versus forced ventilation, particularly the peak values of pressure differences from atmospheric in quiet versus forced ventilation. A pulmonary function test is a non-invasive procedure that measures how well your lungs are working. So it assesses lung volumes, airflow, the efficiency of gas exchange. Pulmonary function tests are essential for diagnosing and monitoring lung diseases, evaluating symptoms like shortness of breath, and assessing lung function before surgeries or in occupational health screenings. We're going to start first with spirometry, which measures the amount and the speed of air that you inhale and you exhale. It's the most common pulmonary function test, and it's crucial for diagnosing obstructive and restrictive lung diseases. It determines the total amount of air that your lungs can hold. So it looks at your total lung capacity and the volumes at different phases of breathing, such as functional residual capacity and also residual volume. So let's take a look at this spirometry image right here and the different lung volume measurements. So first off, you can measure tidal volume, which is the air that's inhaled or exhaled during normal breathing. So it's the amount of air inspired or expired at each breath during your quiet breathing. Then there's the expiratory reserve volume. The expiratory reserve volume is the amount of air that can be forced out after the tidal volume. There's also the inspiratory reserve volume, which is the amount of air that can be forced in after the tidal volume. And then there's also the residual volume, which is the air remaining in your lungs after maximal exhalation. So if you blow out as much as you can, how much air is still left over in your lungs. So with the lung capacity measurements, the vital capacity is the maximum air exhaled after a deep breath. So the maximum amount of air that can be forcefully exhaled after a maximum exhalation. There's also the total lung capacity, which is the total air the lungs can hold after maximum inhalation. So the amount of gas in the lungs after a maximum inspiration. Then there's the inspiratory capacity. The inspiratory capacity is the amount of gas that can be inspired after a normal expiration. And then the functional residual capacity, which is the air left in the lungs after normal exhalation, after quiet breathing. So the relationship between capacity and lung volume. Capacities are the sum of two or more volumes. The vital capacity is the sum of the inspiratory reserve volume, the expiratory reserve volume plus the tidal volume, whereas the functional residual capacity is equal to the residual volume plus the expiratory reserve volume. The total minute volume is the tidal volume times the breaths per minute, the number of breaths that you take per minute, which is generally about 6 liters per minute. So the graph here plots the lung volumes in cubic centimeters over time, and a curve starts from 2400 cubic centimeters and ends at 2400 cubic centimeters after reaching many sequential peaks and troughs. The lung volumes and capacities with their ranges are as follows. You can see that the tidal volume is about 500 cubic centimeters. Inspiratory reserve volume is about 2,900 cubic centimeters. Expiratory reserve volume is about 1,200 cubic centimeters, and residual volume is 1,200 cubic centimeters. The vital capacity is 4,600 cubic centimeters. It includes the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume. The inspiratory capacity is 3,000 cubic centimeters. It includes the tidal volume, the inspiratory reserve volume, and then the functional residual capacity is 2,300 cubic centimeters, and it includes the expiratory reserve volume and residual volume. The total lung capacity you can see here is 5,800 cubic centimeters, and it includes the vital capacity and the residual volume. Make sure you cover table 16.4 in your studies, which goes over ventilation terminologies. Particularly, make sure you understand terms such as anatomical dead space, apnea, dyspnea, hyperventilation versus hypoventilation, physiological dead space as well. So the anatomical dead space is the volume of air in the conducting airways to the respiratory zone. The fresh air is mixed with exhaled air so that the oxygen content is lower and the carbon dioxide content is going to be higher in the external air. The dead space air reaches the alveoli first so that the actual amount of fresh air reaching the alveoli with each breath is going to be less than the tidal volume. Lung disorders often are divided up into restrictive versus obstructive disorders. Starting with restrictive disorders, this primarily involves reduced lung expansion, lung volume loss. Examples include pulmonary fibrosis, sarcoidosis, as well as asbestosis. Problems involved difficulty inhaling, shallow breaths. With a restrictive lung disorder, you'll see reduced FEV1, reduced vital capacity as well, but normal or increased FEV1 to FVC ratio. With obstructive lung disease, the primary problem is oftentimes airflow limitation, mainly during exhalation, so they're having trouble blowing out. Examples include asthma and COPD, as well as bronchiectasis and emphysema. The main symptoms include difficulty exhaling, blowing out. They'll have wheezing or complain of prolonged exhalation. The pulmonary function tests for an obstructive lung disease patient will often times show reduced FEV1, so forced expiratory volume in 1 second, as well as normal or reduced FVC. But the ratio of FEV1 to FVC will oftentimes be decreased. Patients with pulmonary disorders oftentimes will describe a shortness of breath, but this is quite subjective and you have to really quantify it to know what's happening. We've mentioned FEV1, but what is it? It's a forced expiratory volume test, which is a key component of spirometry and is a common pulmonary function test used to assess how well your lungs are working. This measures the amount of air you can forcefully exhale from your lungs in the first second of a rapid, complete exhalation after taking a deep breath, and it's used to assess the degree of airway obstruction. And it's important to note that if the FEV1 significantly is less than 80%, this suggests the presence of the obstructive pulmonary disease. So here we're looking at that 1 second FEV1 test, which is the amount of air that can be expelled from the lungs in 1 second, and it's done using spirometry. In the normal case, for A, the amount of air exhaled in 1 second was 2.5 liters, or 80% of the vital capacity. But in case B, the amount of air exhaled in 1 second was 1.8 liters, or 62.5% of vital capacity. Now, asthma is a chronic inflammatory disease of the airways characterized by reversible airway obstruction, airway hyperresponsiveness, and recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. These symptoms occur especially at nighttime or early in the morning, and sometimes involves increased mucus production. Bronchoconstriction may be provoked by allergic reactions, by exercise, breathing cold air, dry air, or by aspirin. In atopic asthma, also known as allergic asthma, you have a chronic inflammation characterized by hyperresponsiveness to inhaled allergens. This is triggered by allergens stimulating the helper T cells to secrete cytokines that stimulate your B cells to produce antibodies, goblet cells to produce mucus, and airway muscle contraction. And it recruits eosinophils and mast cells in the lungs. Now, in subsequent exposures, the allergen binds to IgEs on the surface of mast cells and basophils, which will secrete chemicals that promote inflammation and others that stimulate bronchoconstriction and mucus production. Treatment for asthma may focus on both controlling asthma or managing the allergies. There's quick-acting beta agonists. These are bronchodilators such as albuterol. There's also long-acting beta agonists such as bronchodilators with glucocorticoids, as well as leukotriene receptor antagonists. These are long-term symptom alleviation effects such as Singular. Emphysema is a chronic lung disease and a form of chronic obstructive pulmonary disease, which primarily involves damage to the alveoli, the tiny air sacs in the lungs responsible for oxygen and carbon dioxide exchange. And over time, emphysema leads to enlarged, damaged air spaces, reducing the surface area available for gas exchange, and it makes it increasingly difficult to breathe. So you've got destruction of the alveoli, reduced surface area for gas exchange, with fewer alveoli to put pressure on the bronchioles. They collapse during expiration, producing air trapping. Smoking is the most common cause of emphysema. It triggers inflammation and destruction of alveoli by immune cells. With COPD, chronic obstructive pulmonary disease, this is a group of progressive lung diseases marked by persistent airflow limitations and breathing difficulties. There are two main forms: emphysema, which involves damage to the alveoli, and then there's also chronic bronchitis, which is a long-term cough that includes mucus. But most people with COPD have features of both of these. You'll see accelerated decline in FEV1. Inflammation involves neutrophils and cytotoxic T cells. There's also excessive mucus production and inflammation triggered by smoking. Most people with COPD also smoke, and there's genetics that's also a factor in this. So the leading cause of COPD worldwide is smoking, and it includes both current smoking and former smokers. In terms of genetic factors, there's a rare inherited deficiency, such as alpha-1 antitrypsin deficiency, that can cause early onset COPD. Smoking also promotes the infiltration of obstructing fibrous tissue and muscle in the airways and remodeling of the blood vessels in the lungs that lead to pulmonary hypertension. It may develop cor pulmonale, which is a pulmonary hypertension with hypertrophy, enlargement, and eventual failure of the right ventricle. There's no cure to COPD, and this is the third leading cause of death worldwide. Pulmonary fibrosis is a chronic lung disease defined by a progressive scarring of the lung tissue, thus the fibrosis, which makes the lung stiff and reduces their ability to transfer oxygen to the blood. The scarring leads to the pattern of restrictive lung disease. This involves a progressive replacement of normal lung tissue with scarred tissue, mainly involving the alveoli and the surrounding lung parenchyma, and reduces the lung's compliance, causing the lung to become less able to expand. Symptoms include shortness of breath that can be progressive, especially during exertion, chronic dry cough. There's also fatigue, joint aches, unexplained weight loss, clubbing of the fingers. If you look at possible causes, oftentimes it's idiopathic, which means that there's no known cause. But there are some possible triggers, including certain medications and environmental or occupational exposures. It may be due to inhaling small particles such as asbestos. Autoimmune diseases and radiation therapy are also possible triggers. Moving on to gas exchange in the lungs. We can study this by measuring the pressure related to this area. Atmospheric pressure can be measured using a barometer. At sea level, the atmospheric pressure is 760 millimeters of mercury, or 1 atmosphere. Atmospheric pressure at sea level, when applied through one end of a U-tube filled with mercury, pushes the mercury through the other end, the vacuum, up to 760 millimeters. Now we come to the concept of Dalton's law of partial pressures, which states that the total pressure exerted by a mixture of non-reacting gases is equal to the sum of the partial pressures of all the individual gases present in the mixture. So this law is fundamental to understanding the behavior of gas mixtures, including atmospheric air and the gases exchanged in the lungs. And it's important to note that the partial pressure of an individual gas can be measured by multiplying the percent of that gas by the total pressure. So oxygen makes up 21% of the atmosphere, and so partial pressure of oxygen would be equal to 760 times 20%, which is 159 millimeters of mercury. So when we look at total pressure, specifically dry pressure, outside of the lungs, the nitrogen makes up 78% of the atmosphere, oxygen makes up 21%, and carbon dioxide makes up 1%. Add up all of those percentages, it comes up to 100%. And so that dry total pressure is going to be equal to the pressure of nitrogen plus the pressure of oxygen plus the pressure of carbon dioxide, and that all totals 760 millimeters of mercury. When the air reaches our lungs, it is humid air, so the calculation changes to accommodate for water, the pressure of water. So the total pressure in the lungs is going to be more wet, and that equals to the pressure of nitrogen plus the pressure of oxygen plus the pressure of carbon dioxide plus the pressure of water, and that all equals to 760. You can see that in the image to the upper right-hand corner there, where the partial pressures of water is on top listed, and then below it is carbon dioxide, oxygen, and nitrogen. And then down below, the lowest row gives you the total pressure. And as follows, let's start first with the inspired air, which is on the left-hand column there. the water is going to be variable. Carbon dioxide will be 0.3 millimeters of mercury. Oxygen will be 159 millimeters of mercury. Nitrogen is 601 millimeters of mercury. So that adds up to 760 millimeters of mercury. But in the alveolar air, the air inside the lungs, the water is going to be 47 millimeters of mercury, so it's more wet. Carbon dioxide is 40 millimeters of mercury. Oxygen is 105. Nitrogen is 568. And then if you total all of that up in the alveoli, that would be the total pressure there would be 760. So when we're calculating the partial pressure of oxygen, the addition of water vapor also takes away from the total atmospheric pressure. So the pressure of water at 37 degrees Celsius is a constant 47 millimeters of mercury. Therefore, the partial pressure of oxygen at sea level would be 0.21 times the difference between 760 minus 47, and that equals 150 millimeters of mercury. So as a result of gas exchange in the alveoli, the percentage of oxygen decreases to about 105 millimeters of mercury, and carbon dioxide will then increase, changing the partial pressure of each of these. Class, make sure you cover table 16.5, which looks at the oxygen pressure changes with different altitudes and locations. So what that means is if you are traveling from sea level to an area above sea level, the partial pressure of oxygen changes, and therefore the amount of oxygen available to your tissues changes. And so your body has to quickly make some changes in order to compensate for this lower level of partial pressure of oxygen. When we look at alveoli and blood capillaries, they have to quickly reach equilibrium for oxygen and carbon dioxide, and this would help maximize the amount of gas dissolved in the fluid. Henry's law predicts this. Henry's law is critical in explaining how gases such as oxygen and carbon dioxide dissolve in blood during gas exchange in the lungs. It states that the amount of gas that can dissolve in liquid depends on 3 items, including the solubility of the gas in the liquid, and in this case it's constant, the temperature of the fluid, which doesn't change for blood, but more gas can dissolve in cold liquid, so colder temperature, more gas can dissolve through it. And then partial pressure of the gases, which is the determining factor. At a constant temperature, the amount of a gas that dissolves in a liquid like blood is directly proportional to the partial pressure of that gas in contact with the liquid. So how this applies to the body is that in the lungs alveoli, oxygen's partial pressure is higher in the air than in deoxygenated blood, so oxygen diffuses into the blood, dissolving according to its partial pressure and solubility. For carbon dioxide, partial pressure is higher in the blood than in the alveolar air, so carbon dioxide diffuses out of the blood into the alveoli to be exhaled. And solubility matters. In the case of carbon dioxide is about 22 times more soluble in blood plasma than oxygen, allowing it to cross even a small pressure gradient efficiently. So we're looking at the relationship between alveoli and capillaries. The pulmonary blood vessels and alveoli relationship is important for exchange of gases between the air and the blood. And the size of the alveoli is also an important parameter, along with partial pressure of gases. The greater the surface area, the more efficient that exchange of gases is going to be. So, what's the significance of measuring partial pressure of oxygen and carbon dioxide in the blood? It's important to note that when we're measuring these pressures, we're only measuring the oxygen that's dissolved in the blood plasma. We're not measuring oxygen that's bound to the hemoglobin in the red blood cells. It does provide a good measurement of lung function, But when lungs are functioning properly, the partial pressure of oxygen of the systemic arterial blood is only going to be 5 millimeters of mercury less than the partial pressure of oxygen of the alveolar air. At normal partial pressure of oxygen of about 100 millimeters of mercury, hemoglobin is almost completely filled with oxygen. The oxyhemoglobin saturation in this case would be 97%. In this case, adding more oxygen will not significantly change the amount of oxygen in the red blood cells, but it can increase the amount of dissolved oxygen. Since the oxygen has to dissolve in the plasma before it can be delivered to the tissue, the rate of oxygen diffusion would increase. But the gas measurement of venous blood is not very useful. So the illustration here shows the arterial blood gas analysis, the ABG analysis, using the partial pressure of oxygen electrode, in which following steps are done. So first, calibration of oxygen electrode using a certified gas cylinder dissolved in oxygen in a beaker and a blood glass machine. The second step involves measurement of the arterial partial pressure of oxygen. So the partial pressure of the gases is an important parameter of efficient gas exchange, and the partial pressure of oxygen differs in arterial and venous blood. Arterial blood has more partial pressure of oxygen and less partial pressure of carbon dioxide, whereas the venous blood has more partial pressure of carbon dioxide and less partial pressure of oxygen. By now, all of us have used a pulse oximeter when we go to the doctors. This is the device that clips on a fingertip or a pinna and non-invasively will measure the oxyhemoglobin saturation. This test or this measurement is non-invasive, it's fast, it uses light. The oxyhemoglobin and deoxyhemoglobin absorbs different wavelengths, and from this information, the device determines the percent of oxyhemoglobin saturation. This value can be abnormally low if gas exchange has been compromised by impaired lung or heart function. When looking at the pulmonary circulation and ventilation perfusion ratios, we can see that the rate of blood flow through the lungs is equal to that through the systemic circuit. So it's generally 5.5 liters per minute of cardiac output. And cardiac output is the amount of blood that leaves the heart per minute. It's generally going to be calculated as the number of beats per minute times the volume of blood that leaves the heart per beat, per squeeze. The systemic circulation pressure difference is about 100 millimeters of mercury. The pressure difference between the left atrium and the pulmonary artery is only about 10 millimeters of mercury. Vascular resistance must be very low. So low pressure or low resistance pathway reduces the possibility of pulmonary edema. It's important to note that the pulmonary arterioles constrict when alveolar partial pressure of oxygen is low, and they dilate when the partial pressure of oxygen is high. Blood flow to the alveoli is increased when they're full of oxygen and decreased when they're not. And this is opposite to systemic arterioles that constrict when the partial pressure of oxygen in the tissues is high, and this ensures that only tissues that need the oxygen are sent the blood. So let's look at the response of the pulmonary arteriole to oxygen. So low oxygen sensed by the mitochondria in the smooth muscle cells initiates events that causes depolarization and opening of voltage-gated calcium channels, which then stimulates contraction and pulmonary vasoconstriction, reducing blood flow. So if you have a low oxygen level sensed, there will be pulmonary vasoconstriction that lowers blood flow, right? The response of pulmonary arterioles to low oxygen levels makes sure that ventilation, oxygen into the lungs, matches perfusion, the amount of blood flowing through there. So here we're looking at the lung ventilation perfusion ratios. The ventilation blood flow and the ratio is as follows. At the apex, 0.24 liters per minute of ventilation. Blood flow at the apex is 0.07 liters per minute. And the ratio of ventilation to perfusion is, so this is the VQ ratio, is 3.4. At the base, notice the difference. So the ventilation at the base is 0.82 liters per minute. Blood flow is going to be 1.29 liters per minute. And the ratio would be 0.63. Disorders caused by high partial pressure of gases typically occur in environments of increased atmospheric or underwater pressure, such as with deep sea divers. There's also the oxygen toxicity, where high partial pressures of oxygen, usually from breathing pure oxygen at increased pressure, like hyperbaric chambers, or deep sea diving, cause oxygen toxicity. And this occurs because the greater amount of oxygen dissolved in the blood increases free radical formation, leading to tissue injury. There's also nitrogen narcosis, where increased partial pressure of nitrogen causes the narcosis of nitrogen narcosis. In this case, nitrogen at higher pressures becomes more soluble in neural tissues, acting as a narcotic. And it causes confusion and impairment of judgment, as well as impaired coordination. There's also decompression sickness, which occurs when divers ascend too quickly. The high partial pressure of inert gases in tissue come out of solution as bubbles when the pressure drops rapidly. Symptoms include dizziness, paralysis. In severe cases, it can also cause death. And this can happen even if you're in an airplane suddenly losing pressure. Hyperbaric oxygen therapy is a medical treatment that involves breathing 100% pure oxygen while inside of a chamber where the air pressure is increased to 2 to 3 times higher than normal atmospheric pressure. And this significantly boosts the amount of oxygen your lungs take in, allowing more oxygen to dissolve in the blood, and resulting in increased delivery of oxygen to the body. How it works is it increases the air pressure. This elevated oxygen level in the bloodstream accelerates the healing in tissues that are damaged or deprived of oxygen, and it enhances oxygen levels, promoting healing and supporting the immune function. It reduces inflammation and can help in removing harmful air or gas bubbles from circulation. This has been approved for treatment for diseases such as decompression sickness caused by rapid pressure changes, also gas gangrene, as well as carbon monoxide poisoning, and severe traumatic injuries, certain inflammations, and diabetic sores as well. Moving on to the regulation of breathing. Contraction and relaxation of breathing muscles is controlled by motor neurons from 2 areas of the brain. Voluntary breathing is controlled from the cerebral cortex, whereas involuntary breathing is controlled from the respiratory control centers of the medulla oblongata and the pons. Motor neurons are involved in regulating breathing. There are those that innervate the diaphragm from the phrenic nerve and arise from the cervical region of the spinal cord. Others that innervate the other breathing muscles arise from the thoracolumbar region of the spinal cord, and they're regulated by descending neurons from the brain or by way of the spinal interneuron. So the medulla oblongata contains crucial neural centers that control the basic rhythm and pattern of breathing. It forms part of the brainstem and coordinates with the pons to ensure proper ventilation in response to the body's metabolic needs. The key respiratory groups in the medulla, there are 2 primary respiratory groups in the medulla oblongata. There is the pre-Botzinger complex, which generates the inspiratory rhythm that has intrinsic rhythmicity, but can also have automatic bursts of activity. It's influenced by both excitatory and inhibitory synapses, so it can be modified for speech or other motor activities. There's another group superior to this pre-Botzinger complex that is active during exercise, but inactive when you're at rest. So it stimulates abdominal and internal intercostal muscles for forced expiration. These both are found in the ventrolateral region of the medulla oblongata, called the rhythmicity centers. The two rhythmicity centers send axons to higher motor neurons in the medulla that, through synapses with spinal interneurons, will control lower motor neurons that innervate respiratory muscles. Higher motor neurons are divided anatomically into a dorsal and a ventral respiratory group, and some innervate the diaphragm through the phrenic nerve during inspiration, while others would inhibit the phrenic nerve during passive expiration. Now that was the medulla. Now we're going to move on to the pons. The pons may influence medulla activity. It has apneustic center as well as pneumotaxic center. The apneustic center promotes inspiration by stimulating medullary inspiratory centers, and the pneumotaxic center inhibits inspiration. The brainstem respiratory centers control breathing largely by way of the phrenic motor nuclei from the C3 to C6 cervical spinal nuclei. Here we can see the brainstem respiratory centers, the midbrain pons and reticular formation in the medulla oblongata are shown. The brainstem respiratory centers, specifically pneumotaxic area and apneustic area, are located in the pons, whereas the rhythmicity area is in the medulla oblongata. Automatic control of breathing is influenced by feedback from chemoreceptors, which monitor pH of fluids in the brain, and also pH, carbon dioxide pressure, oxygen pressure of the blood. Central chemoreceptors in the retrotrapezoid nucleus of the medulla. There are also peripheral chemoreceptors found in the carotid and aortic arteries. There are also aortic and carotid bodies, where the aortic body sends feedback to the medulla along the vagus nerve. Note that the carotid body sends feedback to the medulla along the glossopharyngeal nerve. So again, aortic body, think vagus nerve, cranial nerve number 10. Carotid body, think glossopharyngeal nerve, cranial nerve number 9. These are not the same as the aortic and carotid sinuses that monitor blood pressure, so keep note of that. Now we're looking at the sensory input from the aortic and carotid bodies. Note that the heart, aorta, aortic bodies, sensory nerve fibers in the vagus nerve, common carotid artery, carotid body, and sensory nerve fibers in the glossopharyngeal nerve are labeled here. Sensory branches of the glossopharyngeal and vagus nerves conduct impulses to the brain. Respiration is a well-regulated process by the central nervous system. Automatic breathing is controlled by apneusic and pneumotaxic centers present in pons, which gets the signals from the carotid bodies, and stretch or chemoreceptors. Involuntary breathing is controlled by the corticospinal pathways from the cerebral cortex. Some of you may have heard of Ondine's curse, also known as congenital central hypoventilation syndrome. It's a rare disorder affecting automatic control of breathing. Individuals with this syndrome fail to breathe automatically, especially during sleep, due to a malfunction in the brainstem centers that regulate involuntary respiration. Voluntary regulation of breathing is not affected in this case because it involves descending corticospinal tracts from the cerebral cortex. This condition may result from trauma to the brainstem, but more commonly it's congenital, thus that other name, congenital central hypoventilation syndrome. Patients with this disorder require a tracheostomy and a mechanical ventilator throughout their lives. Ventilation is tightly regulated by blood pH and the partial pressure of carbon dioxide, ensuring stable acid-base balance. The respiratory system adjusts breathing to maintain pH levels within a narrow range, typically between 7.35 to 7.45. When ventilation is not adequate, when you're hypoventilating, the carbon dioxide levels rise and the pH levels fall. So this is called hypercapnia. Hypercapnia means high levels of carbon dioxide. It's because when you breathe, when you exhale, you're blowing out CO2. So if you're not breathing enough, you're not exhaling enough, not enough CO2 is leaving. In hyperventilation, the CO2 levels fall and the pH levels rise. This is hypocapnia. If you're not blowing out, if you're breathing too much, you're blowing out too much CO2. So the level of CO2 within your body is going to be low. Oxygen levels don't change as rapidly because of the oxygen reserves in your hemoglobin. So oxygen levels are not a good index for controlling breathing. Ventilation is controlled to maintain constant levels of CO2 in the bloodstream to keep the PCO2 levels at 40 millimeters of mercury. Oxygen levels naturally will follow. So when we're looking at the effects of pH and PCO2 on ventilation, hypoventilation is at 80 millimeters of mercury arterial carbon dioxide pressure. Normal ventilation will have 40 millimeters of mercury arterial partial pressure of carbon dioxide. And then in case of hyperventilation, we're at 20 millimeters of mercury for partial pressure of carbon dioxide in the arterioles, in the bloodstream. PCO2 is 40 plus or minus 2. In the medulla, there are chemoreceptors. When increased carbon dioxide in the fluids of the brain decreases the pH level, this is sensed by these chemoreceptors in the retrotrapezoid nucleus of the medulla, and ventilation is then increased by way of the pre-Botzinger complex. The arterial carbon dioxide can cross the blood-brain barrier. Note that the blood hydrogen ions cannot, and it reacts with water in the CSF, the cerebral spinal fluid, in order to produce hydrogen ions in the brain interstitial fluid that stimulates the central chemoreceptors. This takes longer, but it's responsible for 70 to 80% of the increased ventilation. Chemoreceptors are found in the medulla. Carbon dioxide in capillary blood crosses the blood CSF barrier and reaches the CSF, where it combines with water to form carbonic acid. The carbonic acid splits into bicarbonate minus ions and hydrogen plus ions. The H plus ions reach the brain interstitial fluid and stimulate the chemoreceptor neurons of the medulla oblongata. Peripheral chemoreceptors, including aortic and carotid bodies, respond to the rise in hydrogen ions in the blood due to increased carbon dioxide levels, and this is due to hypoventilation. These peripheral chemoreceptors respond much quicker. Chemoreceptors control breathing. In this example of negative feedback, a drop in pH is detected by chemoreceptors, the sensors, which communicate to the respiratory center, the integrating center. As a result, the respiratory muscles acting as effectors are stimulated to increase the ventilation of the lungs, thereby bring pH back up to the normal values. Blood oxygen pressure indirectly affects ventilation by affecting chemoreceptor sensitivity to carbon dioxide pressure. Low blood oxygen levels dissolved in the plasma makes the carotid bodies more sensitive to carbon dioxide. Partial pressure of oxygen in blood affects ventilation. When we talk about the hypoxic drive, there's a direct effect of partial pressure of oxygen on the carotid bodies. Glomus cells, located primarily in the carotid bodies, are the central detectors for low blood oxygen, for hypoxia, and play a critical role in the hypoxic drive, the mechanism that increases ventilation when arterial oxygen falls. Glomus cells detect drops in arterial oxygen. Hypoxia inhibits specific potassium channels on the cell membrane. The potassium channel inhibition causes membrane depolarization, which then opens voltage-gated calcium channels. The calcium influx triggers release of neurotransmitters like dopamine and acetylcholine, and these neurotransmitters they stimulate a branch of the glossopharyngeal nerve in the carotid sinus that then sends impulse to the pre-Botzinger complex to increase breathing. So in effect, the neurotransmitters activate afferent nerve fibers projecting to the brainstem, and they signal the respiratory centers to increase the breathing. This is called hypoxic ventilator response. Here we're looking at comparing the effects of blood, carbon dioxide, and oxygen on breathing. Breathing increases linearly with increasing carbon dioxide concentration and decreasing oxygen concentrations is shown before the stimulation of breathing. The curves are labeled. So the pink curve is labeled carbon dioxide varied or oxygen constant, and the blue curve is labeled oxygen varied or carbon dioxide constant. Class, please make sure you look at table 16.6, which is very important. Make sure you're able to summarize the sensitivity of chemoreceptors to changes in blood gases and pH levels. It's important to note that unmyelinated C fibers in the lungs affected by capsaicin produce apnea, then rapid shallow breathing when a person breathes in pepper spray or eats hot peppers. Receptors that stimulate coughing include irritant receptors that are found in the wall of the larynx, which respond to smoke and particles. Rapidly adapting receptors found in the lungs respond to excessive fluid. The Herring-Broer reflex is a protective mechanism in respiratory physiology that helps prevent the overinflation of the lungs. It operates by stretch receptors located in the smooth muscle of the bronchi and the bronchioles, which detect excessive lung expansion during inspiration and triggers a reflex to terminate further inspiration. Cardiovascular responses are also modified to match the ventilation changes. Hypocapnia, also known as low plasma carbon dioxide pressure, is due to hyperventilation when you're breathing very fast. This causes cerebral vasoconstriction, which results in inadequate brain perfusion and hypoxia that can produce dizziness. The hypocapnia of hyperventilation also raises the blood pH levels and produces a respiratory alkalosis, which then lowers plasma calcium levels. This can result in neuromuscular irritability and muscle spasms, as in tetany, in the legs, the feet, and the hands. People can raise their plasma carbon dioxide pressure and alleviate these symptoms by breathing into a paper bag in order to basically collect the carbon dioxide levels. But this could be dangerous for people hyperventilating because of asthma or because they have angina or myocardial infarction. Sudden infant death syndrome, SIDS, sometimes called cot death, is the sudden and unexpected death of an apparently healthy infant under 1 year of age, typically during sleep. It remains the leading cause of death in infants between 1 month and 1 year, and usually it occurs without warning or discernible symptoms. The cause of SIDS is unknown, but evidence suggests that it may be due to a failure of the central or peripheral chemoreceptors to detect a rise in carbon dioxide levels. Obstructive sleep apnea is a common sleep disorder which repeated episodes of blocked, narrowed upper airway during sleep can cause breathing to stop or become very shallow, and these events repeatedly disrupt normal sleep patterns and decrease oxygen levels, often without the individual being aware of it. When the pharyngeal air passages narrow during sleep to cause apnea, the arterial oxygen pressure and oxyhemoglobin saturation fall, and the arterial carbon dioxide pressure rises to stimulate chemoreceptor reflexes, which then can cause the apnea to end with a gasp and a jerk. Dangers include pulmonary hypertension that results in right ventricle hypertrophy, and people with obstructive sleep apnea have to wear a CPAP machine, also known as continuous positive airway pressure devices, when they sleep to keep that oropharynx air passage open. Moving on to hemoglobin and the transport of oxygen. So plasma oxygen concentration in systemic arteries is about 0.3 milliliters per 100 milliliter of blood, and the total oxygen content of blood depends on the partial pressure of oxygen and hemoglobin concentration. Arterial blood can carry 1.34 milliliters of oxygen per gram of hemoglobin, and the normal oxygen content of arterial blood is about 20 milliliters of oxygen per 100 milliliter of blood. We can see in this picture the gas tank has a partial pressure of oxygen of 100 millimeters of mercury. The plasma has oxygen pressure of 100 millimeters of mercury. The oxygen content is 0.3 milliliters of oxygen for 100 milliliters. The whole blood cell has oxyhemoglobin, partial pressure of oxygen of 100 millimeters of mercury, and the oxygen content is 20 milliliters of oxygen for 100 milliliters. Now, most of the oxygen in the blood is bound to hemoglobin. Note that each hemoglobin consists of 4 polypeptide globins, 2 alpha and 2 beta chains, as well as 4 iron-containing hemes, and each hemoglobin can carry 4 molecules of oxygen. 280 million hemoglobins are found within a red blood cell, and each red blood cell can carry over 1 billion oxygen molecules because of this. Please direct your attention to the image on the right where we can see the structure of the hemoglobin. Again, the hemoglobin molecule has 4 heme groups, each surrounded by a globin. 2 of the globins have 2 beta chains and the other 2 have 2 alpha chains. The chemical structure of the heme group shows a central iron bonded to 4 nitrogen atoms that are further bonded to an acyclic compound each, which are all interconnected. Hemoglobin can be found in different forms. There's oxyhemoglobin, where the iron is in its reduced form and can bind with oxygen. When the oxygen is released, the hemoglobin is called reduced hemoglobin or deoxyhemoglobin because the iron is still in the Fe2 plus form. Methemoglobin is another form of hemoglobin where oxidized iron can't bind to the oxygen. This is abnormal. Some drugs cause this. There's also a third form called carboxyhemoglobin, where the hemoglobin is bound with carbon monoxide and has a stronger bond with the carbon monoxide than with the oxygen. Each type has a unique color and absorption spectrum. The percent of oxyhemoglobin saturation, when we look at it, the percent oxyhemoglobin to total hemoglobin is measured to assess how well lungs have oxygenated the blood. So normally it's about 97% oxygenated, or 97% saturated. It's measured with a pulse oximeter or blood gas machine. The oxygen carrying capacity of blood is measured by its hemoglobin concentration. So how much hemoglobin is in the red blood cell. If it's below normal hemoglobin levels, then this is called anemia. Anemia, as you may have learned in anatomy, is the lack of either hemoglobin in the blood or the lack of red blood cells. Polycythemia is when there is above normal hemoglobin levels. So when the hemoglobin levels are higher than normal, this is called polycythemia, and it may occur due to high altitudes. Because in high altitudes, due to the low levels of oxygen in the atmosphere, the body is stimulated to make more red blood cells and therefore more hemoglobins in order to compensate for the low oxygen levels, to try and bring as much oxygen to the tissues as possible. Erythropoietin is a hormone made in the kidneys, which then stimulates hemoglobin or red blood cell production in your red bone marrows when the oxygen levels are low. Testosterone also promotes red blood cell production as well. We can speak of the terms loading and unloading. Loading is when the hemoglobin binds to oxygen in the lungs, whereas unloading is when the oxyhemoglobin drops off the oxygen in the tissues. The deoxyhemoglobin combined with oxygen gives you oxyhemoglobin. The direction of reaction depends on the partial pressure of oxygen in the environment and its affinity for oxygen. High partial pressure of oxygen will favor loading. Low oxygen pressure will favor unloading. Strong bond favors loading and inhibits unloading. When we talked about oxygen unloading, we look at what's happening in the systemic arteries versus systemic veins. In the systemic arteries, they have a partial pressure of oxygen of 100 millimeters of mercury. So there's a lot of oxygen. This makes enough oxygen bind to get 97% oxyhemoglobin. So that's 20 milliliters of oxygen per 100 milliliter of blood. In the systemic veins, you have a partial pressure of oxygen of 40 millimeters of mercury, which makes enough oxygen bind to get 75% oxyhemoglobin, or 15.5 milliliters of oxygen per 100 milliliters of blood. 22% of oxygen is unloaded in the tissues. Take note of table 16.7, which shows the relationship between percent oxyhemoglobin saturation and oxygen pressure at pH of 7.4 and temperature of 37 degrees Celsius. Oxygen remaining in the veins serves as an oxygen reserve. The curve is S-shaped or sigmoidal shaped, where at high partial pressure of oxygen, changes in partial pressure of oxygen have very little effect on loading, but at the steep part of the curve, small changes produce large changes in percent saturation. The oxygen unloading during exercise is even greater than that. So 22% at rest, 39% at light exercise, and 80% with heavy exercise. If you look at the picture on the right-hand side, we're looking at the oxygen dissociation curve. The horizontal axis represents the partial pressure of oxygen in millimeters of mercury. Left vertical axis represents the percent of saturation of oxyhemoglobin, and the right vertical axis represents the oxygen content. Units are milliliters of oxygen per 100 milliliter of blood. A curve starts at 0 and rises gradually to reach 100% at 100 millimeter of mercury. The following points are plotted So you'll notice when you have a partial pressure at 40 millimeters of mercury of oxygen, then the percent oxyhemoglobin saturation is going to be 75. When it's 100 millimeters of mercury of oxygen, then the percent saturation is also 100. On the horizontal axis, point 40 is labeled veins at rest. Point 100 is labeled arteries. The distance between points 15 and 20 on the right vertical axis is the amount of oxygen unloaded to the tissues. Now looking at the effect of pH and temperature on oxygen transport. pH and temperature change the affinity of hemoglobin for oxygen, which ensures that muscles get more oxygen when you're exercising. The affinity decreases at lower pH and increases at a higher pH, and this is the Bohr effect. More unloading occurs at lower pH. Increased metabolism is going to lead to more carbon dioxide and lower pH levels. The more oxygen unloading, the curve shifts to the right. Take careful note of table 16.8, which gives the effect of pH on hemoglobin affinity for oxygen and the unloading of oxygen to the tissues. In particular, also take a look at the effect of pH and temperature on oxygen transport in the image below, where the horizontal axis represents the partial pressure of oxygen in millimeters of mercury, and the vertical axis represents the saturation of percent of oxygen hemoglobin. The three sigmoid curves are shown, each representing the varying pH levels, 7.6, 7.4, and 7.2. The second curve at pH 7.4 shifts to the right when compared to the first curve, 7.6. The third curve shifts to the right when compared to the second curve. This shows the decrease in oxygen saturation percent with decrease in pH. Take note of this. Hemoglobin affinity for oxygen is decreased at increased temperatures. This further enhances the amount of oxygen unloaded to the muscles during exercise, and the curve shifts to the right. Carbon monoxide poisoning may be suspected when the blood carboxyhemoglobin is greater than 10% in smokers or 3% in non-smokers. Carbon monoxide poisoning is usually caused by the burning of fossil fuels, by faulty appliances or vehicles within an enclosed space, and the symptoms may include headache, weakness, dizziness, nausea, confusion, memory loss, psychiatric conditions, as well as cardiac injury. People may be treated for carbon monoxide poisoning by breathing 100% oxygen at 1 atmosphere pressure, or by breathing 100% oxygen at greater than 1.4 atmospheres pressure within a hyperbaric chamber. Red blood cells obtain energy from anaerobic metabolism of glucose and has no nucleus or mitochondria. During this process, 2,3-DPG, 2,3-diphosphoglyceric acid is made. It's inhibited by oxyhemoglobin. 2,3-DPG is produced if a person is anemic or at high altitude, and this increases oxygen unloading. This shifts the oxyhemoglobin dissociation curve to the right. If you look at the picture on the right-hand side, we're looking at the effects of 2,3-DPG on oxygen transport. In the red blood cells, low partial pressure of oxygen at high altitudes causes less oxyhemoglobin, so less saturation of hemoglobin, less inhibition of 2,3-DPG production, increased 2,3-DPG, and lower affinity of hemoglobin for oxygen. This leads to an increased oxygen unloading to the tissues, and it has negative feedback and causes less oxygen delivery to the tissues. Make time to review table 16.9, which shows the factors that affect the affinity of hemoglobin for oxygen and the position of the oxyhemoglobin dissociation curve. When the total blood hemoglobin levels are low, this is anemia. Adult hemoglobin can bind to 2,3-DPG, but the fetal hemoglobin cannot. So hemoglobin F has 2 gamma chains instead of 2 beta chains. The fetal hemoglobin therefore has a higher affinity for oxygen than the mother, so oxygen is transferred to the fetus. So sickle cell anemia is an inherited hemoglobin defect disorder found in 8 to 11% of African Americans. The affected person has hemoglobin S with a single amino acid difference. Deoxygenated hemoglobin S polymerizes into long fibers, and this creates a sickle-shaped red blood cell. This hinders the flexibility and the ability to pass through small blood vessels. So the blood flow to organs is therefore restricted with this sickling of the red blood cells, and the red blood cells then hemolyze, which means that they kind of burst open. It's treated with hydroxyurea and stimulates the production of fetal hemoglobin without the defect. This defect imparts a high resistance to malaria. Transplants of matching hematopoietic stem cells can cure sickle cell disease. Thalassemia is a group of inherited blood disorders defined by reduced production of hemoglobin. When the hemoglobin levels are low, the number of healthy red blood cells drops, leading to varying degrees of anemia. There are different types of thalassemia, and the thalassemia is broadly classified based on which part of the hemoglobin molecule is being affected. Thalassemia is found mainly in people of Mediterranean heritage. Production of either alpha or beta chains is going to be defective. Beta form is going to be more serious than the alpha form. The hematopoietic stem cell transplants can potentially cure the beta thalassemia in childs with a compatible sibling. And gene therapy to produce normal beta chains has had some success as well. Muscle myoglobin is an iron-containing oxygen-binding protein found primarily in cardiac and skeletal muscle tissues. It's crucial for muscle function due to its role in storing and delivering oxygen directly to muscle cells. The structure involves myoglobin being a small globular protein with a single heme group at its core, allowing it to bind oxygen molecules tightly. Its structure is similar but not identical to the hemoglobin found in blood. Myoglobin is composed of 154 amino acids. Now, muscle myoglobin has a higher affinity to oxygen. Oxygen is only released when the partial pressure of oxygen is very, very low. It stores oxygen and serves as a go-between in transferring oxygen from the blood to the mitochondria, and it's particularly important for cardiac muscles. So here we can compare myoglobin versus hemoglobin dissociation curves. The saturation curve of myoglobin shows a steep increase suddenly and is above 95% for the partial pressure of oxygen value of 40 millimeters of mercury in venous blood, and then maintains a plateau. The saturation curve of hemoglobin shows a gradual rise and is about 70% for the partial pressure of oxygen of 40 millimeters of mercury, and rises further. The partial pressure of oxygen of arterial blood is marked at 100 millimeters of mercury. Now we come to the transport of carbon dioxide. Now, carbon dioxide is carried in the blood in 3 forms. First, there's the dissolved form in plasma. It's more soluble than oxygen. Second, it is seen as carbaminohemoglobin attached to an amino acid in hemoglobin. And then third, it's seen as bicarbonate ions and accounts for the majority of carbon dioxide transport. Note that carbon dioxide readily reacts with water in the red blood cell of the systemic capillaries in the plasma. Carbonic anhydrase is the enzyme that catalyzes the reaction to form carbonic acid at high carbon dioxide pressures. So in this case, water plus carbon dioxide will react to form carbonic acid. Carbonic acid is a weak acid that will dissociate into bicarbonate and hydrogen ions, and this reaction also uses carbonic anhydrase as the catalyst. So the formula is carbonic acid transforms into hydrogen ions plus bicarbonate. Once the bicarbonate ion is formed in the red blood cell, it diffuses into the plasma. The hydrogen ion left in the red blood cells will attach to hemoglobin and attract chloride ions. The exchange of the bicarbonate out of and the chloride into red blood cells is called the chloride shift, and this keeps the electrical neutrality of the red blood cell. So I want to direct your attention to the image on the right-hand side here, which shows the carbon dioxide transport and the chloride shift. Carbon dioxide is dissolved in plasma at 10%, and carbon dioxide combined with hemoglobin of red blood cells forms carbaminohemoglobin, 20%. The carbon dioxide plus the water will give rise to carbonic acid, which then gives H plus and bicarbonate minus ions. The hydrogen plus combines with hemoglobin, and the bicarbonate, which is 70%, is released out into the plasma. Chloride enters in. This is the chloride shift. Note the Bohr effect, where bonding of the hydrogen to the hemoglobin lowers the affinity for oxygen and helps with the unloading. This allows more hydrogen ions to bind, which then helps the blood carry more carbon dioxide. In pulmonary capillaries, increased oxygen pressure favors the production of oxyhemoglobin. This makes the hydrogen ion dissociate from the hemoglobin and recombine with bicarbonate to form carbonic acid. That formula shows you hydrogen plus bicarbonate gives rise to carbonic acid. The chloride ion diffuses out of the red blood cell as the bicarbonate ion enters. Shift your attention to the picture to the right. This shows carbon dioxide dissolved in plasma reaches the alveoli. Carbaminohemoglobin in red blood cells dissociates into hemoglobin and carbon dioxide. The latter reaches the alveoli, and chloride ion diffuses out of the red blood cell. An inward flow of bicarbonate occurs. The bicarbonate combines with the hydrogen to give rise to carbonic acid, which then splits into water and carbon dioxide, and then the latter then reaches the alveoli. In low carbon dioxide pressure, carbonic anhydrase converts carbonic acid back into carbon dioxide and water. The carbon dioxide is exhaled and maintains the acid-base balance of the blood in this way. Acid-base balance occurs in the blood. We're looking at the principles of acid-base balance. So acid-base balance is maintained within a constant range by the actions of both the lungs and the kidneys. The pH ranges from 7.35 to 7.45, and since carbonic acid can be converted into a gas and exhaled, it's considered a volatile acid and regulated by breathing. Non-volatile acids such as lactic acid, fatty acids, and ketones are buffered by bicarbonate. It cannot be regulated by breathing, but rather it needs to be regulated by the kidneys. Bicarbonate ion is a weak base and is the major buffer in the blood. Buffering cannot continue forever because free bicarbonate will run out. So the kidneys help by releasing hydrogen ions into the urine and by producing more bicarbonate. If you look over to the right-hand side with that image there, we're looking at bicarbonate as a blood buffer. Carbon dioxide diffuses from tissue cells into red blood cells and combines with water to form carbonic acid, which then splits into bicarbonate and hydrogen ions. Since hydrogen ions combines with hemoglobin and some reach the plasma, chloride shift moves the bicarbonate to the plasma, which then acts as a buffer reserve. It combines the hydrogen and the anion released by non-volatile acid to form carbonic acid. The pH of the plasma is going to be 7.4. When the blood pH falls below 7.35, this is called acidosis, when the pH levels in the blood are too low. Respiratory acidosis is caused by hypoventilation. So when you're breathing very slowly and there's less blowing out of CO2, then you accumulate the CO2 levels, and that increases the hydrogen ion concentration, lowering the pH. Metabolic acidosis is caused by excessive production of acids or loss of bicarbonate, such as seen in the case of diarrhea. When the blood pH rises above 7.45, this is alkalosis. Respiratory alkalosis is caused by hyperventilation, when you're blowing out too much, so you're breathing too fast and blowing out too much carbon dioxide. The hydrogen ion concentration goes down and the pH increases. Metabolic alkalosis is caused by inadequate production of acids or overproduction of bicarbonates, loss of digestive acids from vomiting. Respiratory components of blood pH is measured by plasma carbon dioxide levels, and metabolic component is measured by bicarbonate. You will be using table 16.10, so please make note of this, which gives you the terms used in acid-base balance. We will be covering this in class in detail. Table 1611 will be also very helpful to you in classifying the metabolic and respiratory components of acidosis and alkalosis. So the Henderson-Hasselbalch equation is a fundamental formula in chemistry and biology used to relate the pH of a solution to the pKa, the acid dissociation constant, and the ratio of the concentrations of weak acids and its conjugate base. So a normal blood pH is maintained when bicarbonate and carbon dioxides are at a ratio of 20:1 with this formula. Respiratory acidosis or alkalosis occurs with abnormal carbon dioxide concentrations, whereas metabolic acidosis or alkalosis occurs with abnormal bicarbonate concentration. Note that ventilation controls the respiratory component of acid-base balance. Hypoventilation, when ventilation is insufficient to blow off the carbon dioxide pressure remains high, carbonic acid is high, and respiratory acidosis occurs. When the rate of ventilation is faster than the carbon dioxide production, in the case of hyperventilation, less carbonic acid forms, so the carbon dioxide pressure is low and respiratory alkalosis occurs. Ventilation can compensate for the metabolic component. A person with metabolic acidosis will hyperventilate, blow off carbon dioxide. Hydrogen decreases and pH levels will rise. A person with metabolic alkalosis will hypoventilate. So slow respiration builds up carbon dioxide, which leads to increased hydrogen ion concentrations, thereby lowering the pH. Please review Table 1612, which gives the effect of lung function on blood acid-base balance. Let's look at how respiratory function is affected by exercise and high altitudes. If you think about it, when you exercise, this produces deeper, faster breathing to match the oxygen utilization and the carbon dioxide production. So this is called hyperpnea. There's also neurogenic and humoral mechanisms that control this. There's also a proposed neurogenic mechanism associated with exercise. Sensory nerve activity from exercising muscles stimulate respiration by way of spinal reflexes or brainstem respiratory centers. The cerebral cortex stimulates respiratory centers and helps explain the immediate increase in ventilation at the beginning of the exercise. There's also a humoral mechanism where rapid and deep breathing continues after exercise has stopped due to humoral or chemical factors. The carbon dioxide pressure and pH differences at the sensors are detected, and you have cyclic variations that don't or are not detected by the blood samples that affect the chemoreceptors. So here we're looking at the effect of exercise on arterial blood gases and pH. There are 3 graphs here that plot the changes over time and show a separate curve for moderate and heavy exercise. The partial pressure of oxygen and the pH do not exhibit much changes, but the carbon dioxide pressure decreases during heavy exercise. The lactate threshold is the exercise intensity at which blood lactate begins to accumulate more rapidly than it can be cleared, signaling a shift of going from predominantly aerobic to greater anaerobic metabolism. This point is sometimes referred to as the lactate inflection point or anaerobic threshold. When exercising at or below the threshold, the body can clear the lactate effectively, preventing any buildup. But once the intensity increases beyond this point, lactate production outpaces the removal of the lactate and therefore causes its concentration in the blood to rise exponentially. One of the key facts about lactate threshold during exercise is that the typical threshold is around 50 to 70% maximum oxygen uptake for an average person. So this is due to aerobic limitations of the muscles, not the cardiovascular system, which is still at 97% oxygen saturation. And endurance exercise training increases mitochondria and the Krebs cycle enzymes in the muscles. Please take some time to try to understand the changes in respiratory function during exercise as given to you in Table 1613. In order to acclimate to high altitudes, there are adjustments that have to be made to compensate for the lower oxygen atmospheric levels. This includes increasing ventilation, so breathing more rapidly, increasing hemoglobin's affinity for oxygen so that more oxygen can bind to the hemoglobin at the level of the lungs, increasing total hemoglobin concentration so that there's more carriers for the oxygen transport, and then decreasing blood volume in order to increase the hemoglobin concentration to improve oxygen delivery. It's regulated hormonally by suppressing the renin-aldosterone axis and increasing the atrial natriuretic peptides, as well as the acclimatization timeline. Take note of the trends in blood gas measurements at different altitudes in table 16.14. And so then the body compensates for this change in availability of oxygen. So hypoxic ventilatory response involves decreases in oxygen pressure, stimulating the carotid bodies to increase the ventilation, to breathing faster. Hyperventilation lowers the partial pressure of carbon dioxide, causing a respiratory alkalosis. The kidneys will then over time increase urinary excretion of bicarbonate to compensate for this. The carotid bodies undergo a gradual increase in sensitivity to hypoxia, increasing the ventilation, and after a few days at a high altitude, the total minute volume becomes stabilized at about 2.5 liters per minute above the sea level value. Sympathetic nervous systems also causes a rise in systemic blood pressure at rest and especially during exercise. And nitric oxide is also produced in the lungs that will promote the pulmonary vasodilation and blood flow. Oxygen affinity decreases, so a higher portion of the oxygen is going to unload, and this occurs due to increased production of 2,3-DPG. At extreme high altitudes, the effects of alkalosis will override this, and affinity of oxygen will increase as well. Increased hemoglobin production occurs. The kidney cells will sense decreased partial pressure of oxygen and then produce erythropoietin, that hormone that stimulates production of red blood cells by the bone marrows. Increased red blood cells can then lead to polycythemia, which can produce pulmonary hypertension and more viscous blood. Make sure you study table 16.15, which shows the changes during acclimatization to high altitude. This slide shows the respiratory adaptations to high altitude. The immediate response in a change in ventilation as stimulated by respiratory centers in response to chemoreceptors in the carotid bodies. After a couple of days, another response becomes significant. Increased production of 2,3-BPG in red blood cells results in a decreased affinity of hemoglobin for oxygen. This is the effector response. Days to weeks at high altitude will result in the release of erythropoietin from the kidneys, which is our sensor and integrating center, which then causes the bone marrow to produce more red blood cells and hemoglobin. So at high altitudes, you can have acute mountain sickness, which occurs in up to 25% of unacclimatized people who arrive at an altitude of 2,500 meters, and in up to 85% of people that arrive at 4,500 meters. This includes headaches, which is a common symptom, often accompanied by malaise, anorexia, nausea, dizziness, fragmented sleep. The low arterial pressure of oxygen stimulates vasodilation in the pia mater, increasing the blood flow and the pressure within the skull, and that produces a headache. And this is reduced or prevented by the normal hyperventilation that accompanies acclimatization to high altitudes, which produces a low arterial carbon dioxide levels that stimulates vasoconstriction. The pulmonary arterioles respond in an opposite way to hypoxia as they constrict rather than dilate like systemic arterioles. Now, high altitude pulmonary edema may occur after a couple of days in altitude above 3,000 meters to produce shortness of breath, cough, and cyanosis. After a couple days or so at an altitude of 4,000 meters, a potentially dangerous high altitude cerebral edema may occur and produce confusion, a mild fever, and even coma and death. And there is less likelihood of all of these conditions if the ascent is done more gradually. And that's the end of our lecture, you guys. I'll see you in class. Take care. Bye-bye.